Hello, my name is Gabriel Soriano. My topic is thyroid hormone therapy for older adults with subclinical hypothyroidism. My teacher is John Moscoso. First definition. Subclinical hypothyroidism is an early, mild form of hypothyroidism, a condition in which the body doesn't produce enough thyroid hormones. It is called subclinical because only the serum level of thyroid stimulating hormone from the form of the pituitary gland is a little bit of normal.
Patients will sometimes have a suppressed TSH with normal thyroid hormone levels. This is a condition known as subclinical hyperthyroidism. This can be due to illness, toxic nodules, Graves' disease, resolving thyroiditis, or normal response in early pregnancy. For patients with small, hyperfunctioning thyroid nodules, these release excess thyroid hormone, which acts at the thyroid to decrease the TSH. The low TSH can actually inhibit thyroid hormone production in the remaining thyroid gland, and so thyroid hormone levels can remain normal. For patients with early Graves' disease, the antibody binds to the TSH receptor, which stimulates thyroid hormone production in the thyroid and release of that thyroid hormone into the circulation. This acts at the pituitary to decrease the TSH, which in early Graves' disease is able to regulate thyroid hormone production and maintain thyroid hormone levels in the normal range despite the increased stimulation by the antibodies. For patients with resolving thyroiditis, subclinical hyperthyroidism is seen once the thyroid hormone levels start returning to normal. The TSH is lagging behind. So if labs are checked during this time period, thyroid hormone levels will appear normal, but the TSH has not yet recovered. Clinical complications associated with subclinical hyperthyroidism include decreased bone mineral density, an increased risk of arrhythmias, and possible increased risk of cardiovascular deaths. Given these clinical features, we typically treat patients who would be most at risk from these complications, including elderly patients, patients with a history of cardiovascular disease, and patients with low bone mineral density.
Application in medicine. A small study have reported reduced atherosclerosis and improved heart function with thyroxine replacement. But not large clinical trials have been performed. Therefore, the available evidence is limited, leading to major variation in guidelines and clinical practice, with uncertainty regarding the indication for screening and treatment.
Should I take thyroid hormone if I'm in subclinical hypothyroid range? And that's not really for me to say. I'm not a medical doctor. I don't prescribe drugs. I don't do surgery. I try to help people change the function of their body. That's what my job is. So if you're asking me about whether you should take a drug, I can't answer it. What I can tell you is this. If you have subclinical hypothyroid and you want to get it better,
Pros and cons. Pros. Thyroxine substitution to overcome thyroid hormone deficiencies has the potential to give multi-system benefit to older people with CTH. Cons. The use of levothyroxine to treat subclinical hypothyroidism is controversial.
It's the most prescribed medication in the U.S., with more than 120 million levothyroxine prescriptions written each year. The drug's purpose is to raise low thyroid hormone levels for a condition called hypothyroidism.
But the majority of these patients will be surprised that actually they don't need it.
Mayo Clinic endocrinologist Dr. Juan Brito says more frequent testing is partially to blame, as well as hypothyroidism's very common, somewhat vague symptoms.
Weight loss, hair loss, dry skin, fatigue, low energy. Those are symptoms of many other conditions. Actually, they are symptoms of just life sometimes.
Dr. Brito says that's why many patients' symptoms don't improve with a daily pill. He urges physicians to have valid reasons for prescribing levothyroxine and to follow up in 3 months' time to see if the patient benefited.
And that is the key, is to reassess. The majority of patients get treated and never really have the chance to withdraw the medicine and then just get treated for the rest of their lives.
For the Mayo Clinic News Network, I'm Dennis Doda.
In Ecuador, the incidence of hypothyroidism is 8%. There are many reasons why the development of hypothyroidism is crazy. One of them is radiotherapy.
Hypothyroidism, a diagnostic approach. A 17-year-old girl is brought to your office complaining of progressive weight gain of 4 kilograms or 8 pounds in 6 months, fatigue, and cold intolerance. Her pulse is 55 beats per minute. Other vital signs are normal. Examination shows dry skin and delayed relaxation of the ankle jerk reflex, also termed the Woltmann sign. With these clinical signs of hypothyroidism in mind, thyroid function tests are requested. Laboratory studies reveal increased TSH levels with 12 milli-international units per liter and decreased FT4 levels with 0.3 micrograms per deciliter. Let's take a close look at how to interpret thyroid function tests. The first marker used to assess thyroid function is TSH, thyroid stimulating hormone. If the TSH level is normal, hypothyroidism is unlikely. On the other hand, a high TSH indicates primary hypothyroidism, whereas a low TSH indicates secondary or tertiary hypothyroidism. The next value to look at is FT4, free thyroxine. A high TSH and normal FT4 indicates subclinical hypothyroidism, a condition in which the thyroid gland recognizes thyroid hormone deficiency, resulting in an increased TSH. However, FT4 levels have not yet decreased. On the other hand, decreased FT4 levels suggest a relevant deficiency in thyroid hormones and is classified as primary hypothyroidism. Let's go back to the interpretation of TSH values in the first level of the flowchart. A low TSH level together with a low FT4 would suggest secondary or tertiary hypothyroidism. Secondary hypothyroidism is due to the failure of the pituitary gland to secrete TSH, whereas tertiary hypothyroidism is caused by the failure of the hypothalamus to release TRH, a thyrotropin-releasing hormone. In both cases, the thyroid gland does not produce enough FT4, causing hypothyroidism. To confirm the exact cause, further follow-up is required. Okay, let's analyze the patient's laboratory findings. The reference value for TSH is 0.5 to 5 milli-international units per liter. An elevated TSH value of 12 was found. The reference value for FT4 in adults is 0.7 to 1.8 micrograms per deciliter. A low FT4 of 0.3 was detected in the patient. Based on these laboratory findings, the patient has primary hypothyroidism. Information regarding further follow-up and management can be found in the respective chapter.
Subclinical hypothyroidism is a possible contributor to many problems in older persons. Levothyroxine provides no apparent benefit in older persons with subclinical hypothyroidism.
Today we will be talking about subclinical hypothyroidism. Definition. Subclinical hypothyroidism is defined by a low or undetectable serum TSH level, with normal free T4 level. Causes. Subclinical hypothyroidism may result from endogenous overproduction of thyroid hormone. Common causes of endogenous subclinical hypothyroidism include Graves' disease, autonomous functioning thyroid adenoma, and multinodular toxic goiter. Subclinical hypothyroidism may also be caused by excessive thyroid hormone replacement therapy in patients with hypothyroidism. transient TSH suppression may occur during subacute, painless, or postpartum thyroiditis. Diagnosis. A clinical history can distinguish subclinical hypothyroidism from other causes of low TSH not related to thyroid overactivity. For example, the use of certain drugs such as dopamine or glucocorticoids, pituitary and hypothalamic deficiencies, and psychiatric disease such as affective disorders. In general, free T4 levels tend to be lower in persons with these conditions, whereas persons with subclinical hypothyroidism may have free T4 in the mid to high reference range. Reassessment of TSH and free T4 levels is appropriate after 2 to 4 months to evaluate whether low TSH is persistent and whether subclinical thyroid disease has progressed to overt hypothyroidism. Natural history. Subclinical hypothyroidism progresses to overt hypothyroidism in a minority of patients. The rate of progression to overt hypothyroidism is higher in persons with TSH levels less than 0.1 milli-IU per liter in general. Subclinical hypothyroidism is associated with an increased risk of atrial fibrillation and heart failure in older adults, increased cardiovascular mortality, and decreased bone mineral density with increased bone fracture risk in postmenopausal women. When to consider treatment. Current guidelines recommend treating patients with TSH levels persistently less than 0.1 milli-IU per liter if they are 65 years or older. If they are younger than 65 years and have heart disease, osteoporosis, or symptoms of hypothyroidism, or if they are postmenopausal, younger than 65 years, and not taking estrogen or bisphosphonates. Treatment should be based on the underlying etiology of subclinical hypothyroidism. Antithyroid drugs and radioactive iodine are appropriate treatment options in patients with Graves' disease. In patients with toxic multinodular goiter or a solitary autonomous nodule, radioactive iodine ablation or surgery is preferred because spontaneous remission is unlikely to occur. In summary, subclinical hypothyroidism is defined by a low serum TSH level, with normal free T4 levels. It can be caused by increased endogenous production of thyroid hormone, for example in Graves' disease, toxic nodular goiter, or transient thyroiditis. It can also be caused by excessive replacement therapy. The rate of progression to overt hypothyroidism is higher in persons with TSH levels less than 0.1 milli-IU per liter. Current guidelines recommend treating patients with TSH levels less than 0.1 milli-IU per liter if they are older than 65 years or have comorbidities such as heart disease or osteoporosis.
Audio Jungle. Audio Jungle.
Thank you for your attention.